Good morning, everyone, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Sarah Dudley with the New England QIN-QIO, and this is part 2 of our 2-part webinar series on improving nursing home resident mobility. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation, and we ask that you do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Make sure that you send your comments to all participants. Doreen from the New England QIN-QIO team in Connecticut will be monitoring and responding to questions and comments in chat. We will also have plenty of time for questions at the end of the presentation, and we'll open the lines back up. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right corner of the presentation window to adjust your screens accordingly. On part 1 of this webinar series, we discussed how encouraging nursing home resident mobility can lead to improvements in several quality measure outcomes. We identified strategies to take a person-centered approach to reduce falls and eliminate the use of bed and chair alarms. We also reviewed the nursing home change package and how to apply strategies from the mobility bundle. On today's webinar, we are joined by presenters from Genesis Healthcare in Connecticut and Soldiers Home in Massachusetts for the second part of our webinar series on improving nursing home resident mobility. During this webinar, you'll hear from Florence Bolella, Debbie Antonelli, and Chad Moran. During this session, you'll learn strategies to help your residents improve mobility and reduce falls, become an alarm-free facility, overcome fast reactions, and sustain improvements. You'll also learn how to develop a falls program that includes hourly rounds, post-fall assessments, and other resources. To kick off today's first presentation, I want to introduce to you Debbie Antonelli. She is the Director of Nursing Services at the Chelsea Soldiers Home in Chelsea, Massachusetts, along with Chad Moran, who is the Performance Improvement Coordinator. Debbie and Chad, I'm turning it over to you.
Good morning, everybody. We're happy to present to you the recent performance improvement process that team here at Chelsea Soldiers Home is involved in. Our project initiated in October 2015. Yes?
Buddy, we're having some hard time hearing you. It's very muffled and it's breaking up a lot.
All right. Can you hear me now?
Try one more time.
Can you hear me now?
Yeah, we can. It's still a little choppy. That's a good word. But we'll see if it gets any better.
We're happy to present to you some research that we have collected and data that we have collected over the last 12 months on reducing fall rates within the Chelsea Soldiers Home. We were asked to be part of a national effort with state veteran homes to work on best practices in reducing falls within the state veterans homes. And our results have been remarkable. So go to the next slide. So we initiated a falls committee, and we took an interdisciplinary approach to this fall committee. As you can see by this slide, the committee involved the director of nursing, the medical director, compliance officer, a nursing supervisor, rehab services, and any other team members that wanted to be included in the fall initiative. So the next slide. Our focus was the entire facility. The facility has 10 nursing units, 5 of which are skilled nursing, and the other are long-term care nursing. Our goal is to create a fall committee that can work on identifying the reasons for fall, whether it was environmental, acute care processes, and critically look at our systems which contributed to fall. Our fall committee presently meets twice per week. We meet on Tuesdays and Thursdays, so that captures our falls from the weekend and also captures our falls from during the week. We do a post-fall automatic referral to rehab services for assessment on all falls.
So the slide you see here is a decision tree that we obtained through the VA for our breakthrough series, which, other than the initial intervention discussed when the staff responds to the medical stat on the unit to find out how the fall occurred and how we could intervene, this tool here helps us to further develop an approach on the Tuesday and Thursday meetings to go back and ask questions, even though we already have answers to really break it down to specific reasons to form a good plan.
So with each fall, the nursing staff automatically produces an order for a PCOT rehab assessment, and then they will complete a consult sheet and submit to the rehab team. We take a multi-system approach with follow-on systems review, follow-on bladder, restorative, psychotropic med use, any behaviors, any need for updating of policy and procedure, as well as the development of new assessment forms, which we all know our teams love, new assessment forms, and working through consistent assignment of staff. We worked also on improving our dining program to make sure that there was more administrative focus in our dining room areas, and that enables staff to monitor high-risk fallers in the dining areas. And we also introduced a post-fall huddle sheet. We have a two-part goal. Our center was seen as many as 75 falls per month. Our primary goal is to reduce the number of falls, and our second goal is to work on reducing injury with falls, major injuries such as fracture. I'm proud to say, honestly, that we have reached this goal. We're averaging 35 falls per month. Right now, our average is low 6 per month. In the past 18 months, our highest was 18 falls per month. So the major reduction in minor major injuries for all of our veterans. We have a fall assessment tool that we are going to share with you. I believe it's on an additional slide, and that assists us in working through all processes. The fall assessment tool is also utilized at the unit during a post-fall huddle. We had challenges, of course, to keep the staff engaged and focused on the need to continue critical interventions for patient safety. We introduced the 5 Ps. So all staff members, when they see somebody trying to raise up a chair or an environment of high-risk fallers, the first thing we do is we assess for pain, whether or not they need to go to the bathroom. We readjust position if necessary. Is it a possession issue? Do they want to stop, or do they want their wallet? And is there any obstacles in their way that might increase risk of fall? Here's an example of what we posted on every unit. The slide, every nurse today knows for the high-risk faller, safety, abnormal movement is the first intervention at the bedside, or at the dining area, or in activities.
As we mentioned before, the fall committee does meet twice a week after the initial intervention is in place, and we do bring the residents charts and make additional changes to any care plans, make sure they're updated. There is a representative from the unit in which the resident lives to assist and add input onto what will better help the resident going forward and how to prevent that same resident to fall. Because another thing that we do focus on is trying to eliminate repetition of the same resident falling. The post-fall huddle, which I'll show you on the next slide, is utilized for each fall by the fall committee. We do have changes to processes by policy and procedure, which is updated as needed. And intentional rounding is another thing that we implemented to have a more active approach to not only the high-risk fallers, but all residents residing on the unit to prevent anyone that's not considered a high-risk faller from having falls. So on this page here, this is the post-fall huddle page, which I, as a compliance officer, will review as part of my investigation to see, how the fall occurred, make sure we have appropriate interventions in place. When the medical team arrives, this form is brought to the scene of the fall, and these questions are all asked, which helps us again to focus in on specific information. If you look at the second box down, we go even as far as what type of footwear was on there, shoes, socks, barefoot, if they had grips on them, one sock on, one sock off, if they had their cane or the walking device with them, if there were any obstacles in place, exactly like that. And go on to the next slide. And then this slide would be the intentional rounding form that we have in, which helps the staff to also have a safe check on where residents are. If you look on the right side of the slide, we have the abbreviations on how the staff person assigned during that hour when making their rounds with each resident, how they can code the resident's location or what they're doing. And that way we have an hour-by-hour approach to keep track of the high-risk fallers, which, again, has helped us tremendously reduce our number of falls, and we've gone from 8, 9, 10 major injuries a month down to maybe 1 or 2 each month, which that is a second to our focus of, having 0 falls, but if a fall does occur, we do want to make sure that there's as little injury as possible to our veterans.
And I just want to add to the intentional round, and it's hard to have total team buy-in when you're asking them to do another record or documentation of actual hands-on rounding. So what we did here systematically is we had nurses supervisors round the unit to ensure that the direct care workers were documented, that they did check, and to watch and see and evaluate the effectiveness of that rounding. And our results this month, we've had 6 falls this month. 3 of them have resulted in injury, but it's a far cry from 75 falls per month. So that's a work in progress still, and we're always looking for ways to improve that. And I'm interested in hearing what Florence has to say about decreasing alarms in the facility, because that's our next step. So I'll turn this over to Florence.
Thank you.
Okay. To Sarah.
You can hand it back. You can hand the ball over to Florence. Thank you, Debbie and Ted. The work that your team has done to prevent falls is impressive, and it's just proof that it really takes a team. Debbie and Ted will be available for questions and answers following our second presentation. At this point, I'm going to introduce Florence Varela. She is the Clinical Reimbursement Coordinator at Kimberly Hall South, a Genesis Healthcare facility in Windsor, Connecticut. Florence, I'm going to turn it over to you. Do you have the ball? Yep.
Yes, Sarah.
I'm sorry, we couldn't find Florence on our list.
The ball disappeared from our screen.
Emily or Jennifer, are you guys still on the line? If you could pass the ball to Florence.
Thank you. Sorry about that.
Next speaker.
Thank you.
Hold on 1 second, Sarah. Emily, are you on the line? Can you change the ball to be Florence, please?
In the meantime, Florence, why don't you get started, and Debbie, if you could advance the slides over to Florence's first slide, we can get started.
Okay, can you hear me well?
Yes, we can.
Okay, thank you very much for inviting me to talk about alarm reduction. Back in 2012, Genesis gave us the initiative to become alarm-free. And this is where the tortoise and the hare story comes in. I chose to do the tortoise route, which honestly took me almost a year to remove all alarms. Some facilities did pick a date and then go alarm-free with all the residents, and found that to be a bit overwhelming. So don't be afraid to take your time, because ultimately it's reaching the goal of being alarm-free. That's what's important. The first step was education.
This is Morgan. You actually have the ball now, so make sure to advance your slides.
Thank you. Okay. So your first step is education. When we told our staff we were going to reduce and eliminate alarms, their response literally was, "Flo, you are crazy." So education is very important, and you need to just discuss the negative effects of alarms. You need to bring it to your residents. We brought it to resident council prior to beginning so that our residents would be aware, and they were actually very excited and happy to hear that we were going to reduce alarms. And then, of course, your families. And what took me so long to remove all my alarms is I did have one family that said, "No, you're not going to take that alarm away." So, I mean, that's sometimes what you have to encounter. Alarms really just, they're not, you need to be proactive, not reactive, and that's what happens with alarms. So in research, we found, alarms create a lot of noise and fear, agitation in our confused elderly residents. We don't really address the underlying need of why a resident might be standing up and sounding the alarm. Instead, we tend to say, "Sit down, Mr. Smith, sit down, Mr. Smith." Alarms decrease overall mobility, causing increased weakness, decreased balance and endurance. And honestly, it's embarrassing to have an alarm. I don't think any of us would want to shift our position and have an alarm go off. Alarms can increase skin breakdown from immobilization. The residents are afraid to move because the alarm goes off. Decrease their bowel and bladder function. Induces agitation. And many often we found with our alarms we had false positives or false negative events where our alarms did not sound. Sometimes our alarm sounded 5 or 10 minutes after the resident was removed off the alarm. So before you begin your process of eliminating the alarms, make sure you have a good fall prevention program. If you have a restorative program to focus on strengthening, it's definitely interdisciplinary approach to falls. Quality of life rounds we have weekly, so we reviewed every resident. It's a good opportunity to see if there's any change in the resident and get therapy involved prior. And then your CNAs can be cross-trained to provide some recreational programs or activities on the unit, so that keeps our residents busy. So set a goal. For example, if you have 24 alarms in the facility and you want to take 6 months to reduce your alarms, reduce just 4 a month. You don't have to reduce a lot. So review each resident, look back at their fall history. Is there any patterns? Are they still mobile? Do they need a toileting plan? Look at the room. Is it cluttered? Where do we place their walker and wheelchair when they're in bed or out of bed? And initially choose your resident for reduction carefully. This is very important. If you're successful on the first few residents, then the staff, residents, and families are going to buy into reducing the alarms. Meet weekly with the team. Make sure everybody knows who's being reduced that week and how they're doing after the alarm is reduced. And then share your fall percentages. Prior to beginning, we did have significant falls, but afterwards, and still 5 years later, our fall percentages are lower. In the end, you are definitely going to have very peaceful, quiet units. You're going to decrease the agitation in your residents as well as their roommates who have to listen to the alarms going off. You're going to increase staff satisfaction through the elimination of alarms, a cost savings, but most importantly, a reduction in falls and much happier residents. And that's what I have.
Thank you, Florence. If you can pass the ball back over to me, we're going to open up the lines for Q&A. As a reminder, to unmute your line, beyond just your manual mute button on your phone, you do need to press #6 to ask a
The
question.
leader has unmuted your line.
To ask a question for one of the presenters. You can also ask a question in chat. The chat box is in the bottom right-hand corner of your screen. Has anyone joined the line to ask a question? Doreen, do we have any questions in chat?
I do not have any yet.
Great. I do see that we have a comment or a question in chat from Gail. She said, great program, intentional rounding challenges. Do you assign just CNAs to round on their own residents, one CNA to round on the unit of all residents each hour? Have you involved staff members other than nursing, example, activity staff? Does anyone have any ideas that have helped with intentional rounds?
Oh my God.
Florence, would you like to answer that one?
Am I still unmuted here?
Who's supposed to be available?
You're on. We hear you.
As far as the rounding, it's all staff members, housekeepers, dietary aides. Everyone needs to be on the lookout when they come down the hallway. The CNAs and the nurses obviously are on the units most, so as we're going up and down the hall, we need to peek in on our residents. And so it can't just look at just your own assignment. You need to look at every resident.
Thanks, Florence. We have another question. Will your tools and the poster be available to the audience? Would you be able to share those tools and the poster with, you could send that over to me and I can make sure that goes out in the thank you email that goes out the following day.
Yes.
Do we have anyone else that has joined the line? Yes? Morgan, can you remute the line?
Yeah, so sorry guys, the phone lines got unmuted, so I'm going to remute them. You can then press *6 to ask a question. Or #6, I'm sorry. So I'm going to mute the lines and then you can press #6 to ask a question.
The leader has muted your line. To unmute your line, press #6.
Thank you, Morgan.
So, Sarah, it's Debbie Antonelli. I wanted to add to the intentional rounding question.
Yes.
I just wanted to tell the audience that what's been really effective here, yes, it does take a whole team to monitor what's necessary to maintain a safe environment. However, we make one CNA in charge of the unit to do those rounds, and the charge nurse is responsible to check those flow sheets every hour to ensure that rounding is happening. And we put a third buffer in for nurse and administration to round and also see that the forms are completed and the rounding is actually happening. And with that, we've had amazing staff buy-in to the point that now when I do rounds on the unit, everybody wants to show me that their sheets are complete and they did their rounding and they had no falls. So I think once they see that's effective, then you have a positive outcome and people are willing to participate.
Thank you, Debbie. We have another question for you, Debbie, from Rosemary in chat. Can the Chelsea home discuss further the post-fall huddle? I assume that's all shifts and not the interdisciplinary when possible.
Correct. So post-fall huddles happen in 2 phases. They're at the time of the event. No matter what shift, what day of the week, nurse and staff with other available staff interdisciplinary-wise and the nursing supervisor review the fall area, document where they were when the fall happened, and what kind of barriers by using that fall assessment huddle. Then on Tuesday mornings and Thursday mornings, the fall committee meets and reviews the statement, reviews the direct care workers assessment of that fall, and then looks as an interdisciplinary approach, is there something that we missed? And at that time, we do a chart review, care plan review, and a CNA care card review to make sure that everybody is doing the exact same thing in mobility for the best maintenance possible of that veteran. Does that help?
Thank you, Debbie.
Okay, Sarah, we have a question from Jason Plant. In terms of guidance for the fall prevention team, should the overall philosophy be that all alarms are bad, or are there appropriate times for use of an alarm?
You have to look at all your residents. Look at all your residents individually. We wanted an alarm-free facility, so that was our goal. It did, as I said, take a while for some of our residents to become alarm-free because of resistance either from the family, or we had some residents that were very high-risk fallers that we kept towards our end of our goal. It's really up to the team and the resident who you decide to remove the alarms on and who you decide to keep alarms on.
Thanks, Florence. Do we have anyone else that's joined the line with a question? Doreen, are there any other questions in chat?
No, Sarah, not yet.
Doreen, could you pass the ball over to me? I believe you have the ball. Again, as a reminder, to ask a question over the phone, please dial #6.
You should have it now, Sarah.
Thank you. Right, it looks like we don't have any other questions. Thank you all for the great questions that you had in chat, and thank you to our speakers. This is very informative, and I hope that it helped everyone out who joined us today. If you weren't able to ask a question during today's session, you can reach out to your QIN-QIO Nursing Home State Lead. We've listed their contact information here on this slide. And don't forget to mark your calendars with upcoming collaborative events and educational opportunities, including on September 14th. We have another webinar with the Maine Veterans Home, who will be sharing their antibiotic stewardship program with you all. On September 21st, we have an in-person event called Getting It to the Root Causes of Resident Falls with Suzanne Gilderman. And then we have another in-person event on September 26th, Assessing and Managing Pain seminar with special guest speaker Carol Curtis. Check out our website, healthcarefornewengland.org, for more information or to register. In addition, the next CMS MLN Connect call is scheduled for next Thursday, September 7th from 1:30 to 3 o'clock. This call will include an overview of the new facility assessment tool. And they will also cover frequently asked questions related to the revision of the State Operations Manual, Appendix PP, for Phase 2 of the Reform of Requirements for Long-Term Care Facilities Final Rule. We will include a link to register for this call in the follow-up email for this webinar. We also have our winners from the Facebook contest from part 1 of this webinar series. Congratulations to Kathy Dion. You have won 2 tickets to the in-person event, Getting to the root causes of residents' falls, presented by Sue Ann Gilderman. That's in Wallingford, Connecticut, on September 21st. Please reach out to Morgan Gargiulo with the New England QIN-QIO, or send us a quick note in chat. Morgan, if you can provide your email address in chat for her. So if you would like to join another contest to win free tickets, you've seen it. All you have to do is go onto Facebook and follow us. If you're already following us, please go onto Facebook and share the post about this contest. We are now giving away tickets for our Assessing and Managing Pain seminar, which takes place later next month. So between today and September 13th, go on to Facebook, like us, follow us, or share that post, and you'll be entered to win 2 free tickets to the pain conference. Following today's webinar, you will be directed to a survey to provide feedback on the webinar. Your input really helps us to improve these educational sessions and provide us with meaningful programs in the future. Also, within the next few business days, we will send out an email to everyone that contains links to both today's presentation, the resources that we mentioned earlier on today's presentation, and then a recording of this webinar. Thank you all for attending today's webinar, and have a great day.
The leader has disconnected. The conference will be terminated in 5 minutes.